Welcome to the session of spatial stain. Spatial stains are different from routine Romanowski stains. They are used to detect specifications like reticulocytes or iron store in the bone marrow or ring sideroblast and differentiating certain type of leukemia like monocytic leukemia or hairy cell leukemia or CML. Spatial stain for RBCs are Retic stain, Perls, Prussian blue stain. For WBC, there are Sudan Black B, Myeloperoxidase, periodic acid Schiff, Tartarate resistant acid phosphatase, non-specific Esterase, Leukocyte alkaline phosphatase stains. First, we see the reticulocyte stain. Reticulocytes are the immature RBCs produced in the bone marrow and released into the peripheral blood, where they mature into RBC within 1 to 2 days. Flow cytometry is a faster and more precise way of measuring reticulocyte. Other manual standard technique is new methylene blue stain. This stain is designed to highlight the RNA as a blue color. The stain allows cells to be recognized by the blue intracytoplasmic precipitate, ranging from appearance of the granules to a network of reticular material. Manual technique is useful in under-resourced laboratory. Procedure of the stain. Take 2 to 3 drops of the dye solution in the test tube. Add 2 to 4 drops of well-mixed blood sample and mix. Stopper the tube and incubate at 37 degrees for 10 to 15 minutes. After incubation, mix well and make a thin smear of a stained blood. When dry, examine the films without fixing or counter stain under the 100x lens. Count 1000 RBCs and note the number of reticulocytes among them. A dark blue reticulum or network will present in the reticulocyte. Formula for reticulocyte count. Reticulocyte count percentage is equal to reticulocyte number in 1000 RBCs upon 1000 RBCs into 100. Normal reference range is 0.5 to 2.5%. When the patient's HCT is not ideal, then we have to correct that reticulocyte count. The formula for corrected reticulocyte count is obtained reticulocyte percentage into patient's HCT upon 45, which is ideal HCT. Reduced reticulocyte percentage seen in ineffective erythropoiesis and bone marrow suppression. Increased reticulocyte percentage seen in hemolytic disorders, whether intrinsic or extrinsic. The next stain we are learning is Perl's Prussian blue stain. To demonstrate the ferric ion in the RBCs and the macrophages, the Perl's Prussian blue stain is used. Granules containing ferric ion react with the potassium ferrocyanide to form a blue compound, ferric ferrocyanide. It is called the Prussian blue reaction. Procedure is take the test and the control slides and fix it with the methanol for 10 minutes. Leave it to dry. Prepare the working solution by adding 30 ml 2% potassium ferrocyanide and 30 ml 2% HCl in the Coplin jar. The ratio of ferrocyanide to HCl is 1:1. Submerge the slide into this working solution. Leave it at room temperature for 1 hour or incubate in a water bath at 37 degrees centigrade for 20 minutes. Wash the slides in the running tap water for 3 to 5 minutes. Then counter stain with saffron in. Dry and cover the slide with the cover slips. It is used to demonstrate iron, especially in the blood and the tissue such as bone marrow and the spleen. It is used to identify the Pappenheimer bodies in the peripheral blood smear. It is used to identify the ring sideroblast in the bone marrow aspiration smear. It is also used to demonstrate the iron deposit in the liver in the hemochromatosis and in the lungs in congestive heart failure. The next stain is Sudan Black B. Sudan Black B dye is a fat soluble, so it stains the fat particle which is present in primary and secondary granules of myelocytic and monocytic cells. It is used to distinguish acute myelogenous and monocytic leukemia from the acute lymphocytic leukemia. Materials required for the stains are fixative required 40% formaldehyde vapor, SBB stain 0.3 gram per 100 ml of 100% ethanol, phenol buffer dissolve 16 gram of crystalline phenol in the 30 ml of 100% ethanol to create the phenol buffer. It is then added to 100 ml distilled water and 0.3 grams of sodium phosphate dibasic dodecahydrate is dissolved. Working SBB stain solution. Add 40 ml of buffer to 60 ml of SBB solution to make the working staining solution. Counter stain with May groundworld Jimsa or Leishman counter stain. Procedure. Fix the air dry test and control smears for the 10 minutes with the formalin vapor, formaldehyde or the formalin ethanol fixative. Wash with the water for 5 to 10 minutes. Place the slides in the coupling jar with a lid and the working solution for 1 hour. Remove and flood the slides with 70% alcohol for 30 seconds. Repeat this with 3 times. Rinse in running tap water and air dry. Counter stain without further fixation with Leishman stain or Jimsa stain. Air dry and examine microscopically. Other indications of Sudan Black B is lipid droplet analysis. The primary application of SPB staining is to visualize and quantify lipid droplets in biological samples. Determine the amount of fat in the feces in order to diagnose the steatorrhea. It is used in metabolic disorders. The staining can be used to study the lipid droplets in the context of metabolic disorders such as non-alcoholic fatty liver disease and type 2 diabetes. The next stain is myeloperoxidase MPO. It is used to differentiate acute myelogenous or monocytic leukemia from the acute lymphocytic leukemia. Myeloperoxidase is present in the primary eosinophilic granules of the neutrophil, eosinophils, and monocytes, and activity is increased with maturation, and no activity is found in red blood cells or lymphocyte. Peroxidase in the leukocyte granules oxidize benzidine to form insoluble, stable, and non-diffusible reaction product in the presence of hydrogen peroxide. This product is colorless to blue or brown derivative, which is localized at the site of the enzyme. Copper sulfate or the nitrate can be used to enhance the staining. Material required for the staining is fixative. It is 10% formal ethanol or the buffered formal acetone. Substrate required is benzidine or diaminobenzidine. Buffer Sorensen phosphate buffer pH 7.3, 3% hydrogen peroxide and working substrate. Add 30 mg of DAB in the 60 ml of buffer. Add 120 microliter of hydrogen peroxide and mix well. Counter stain required is hematoxylin. Procedure. Fix the test and control slide in the formal ethanol or the buffered normal acetone for 60 seconds. Rinse in running tap water for 30 seconds. Put the working substrate on the smear and incubate for 10 minutes. Wash gently with running tap water for 30 seconds. Counter stain with hematoxylin for 3 to 5 minutes. Rinse in running tap water and air dry and examine under the microscope. If more than 3% of the blast is MPO positive, then the case is reported as MPO positive, and if the less than 3% of the blast come positive, then report is considered negative. The neutrophil eosinophil monocyte AML M1 M2 and microgranular M3 and granulocytic sarcoma are MPO positive. Lymphoblast and lymphoid cells are MPO negative. The next stain is periodic acid Schiff. The technique works by applying the periodic acid solution to the sample, which oxidizes units within the polysaccharide, creating aldehyde group that react with the colorless Schiff reagent, thereby producing a deep magenta product. The stain turns anything with polysaccharides magenta, including glycogen, glycoprotein, glycolipid, mucin, and other molecules with polysaccharide moieties. Procedure: fix the air dry test and control blood films for 1 minute at room temperature in formalin ethanol fixative solution. Rinse the slide 1 minute in slowly running tap water. Place the slide on the flat surface and pour 1.5 to 2 ml of periodic acid solution on the sample. Incubate for 5 minutes at room temperature. Rinse the slide in the several charges of the distilled water. Pour 1.5 to 2 ml of Schiff reagent on the slide and incubate it at a room temperature for 15 minutes. Wash the slide with distilled water for 5 minutes and leave it to air dry. Counter stain slide with hematoxylin solution for 90 seconds. Rinse the slide in the running tap water for 15 to 30 seconds. Air dry, examine microscopically under the oil immersion lens. It is used to stain the lymphoblast in acute lymphoblastic leukemia. Most types of acute myeloid leukemia are negative for PAS, but exceptions are pro-normoblast in the pure erythroid leukemia, M5A, M6, and M7. It is also used to stain the Putrier microabscesses in the mycosis fungoids. The next stain is called TRAP. It is tartarate resistance acid phosphatase. Its main diagnostic use is in the diagnosis of T-cell acute leukemia and hairy cell leukemia. Principle is the acid and alkaline phosphatase includes a range of isoenzymes with a general ability to liberate the phosphatase from many alcoholic or phenolic phosphomonoesters at acidic or alkaline pH. Material required are 4% sodium nitrite, pararosalilin hydrochloride, acetate buffer, 2% methyl green, naphthol ASB1 or ASMX, sodium tartarate. Procedure: take 2 slides, one for acid phosphatase and other for tartarate. Fix the slide with formaldehyde vapor for 20 minutes. Take 40 ml of acetate buffer in the beaker, pH 5.2. In the test tube, take 10 mg of naphthol ASB1 or ASMX in 1 ml of N,N-dimethyl formaldehyde. In a beaker, take 0.8 ml of 4% NaNO2, add 0.8 ml of pararosalilin, mix it thoroughly for 1 minute continuously, and fishy odor will come. In this mixture, add the acetate buffer and add the naphthol ASMX or dimethyl formaldehyde mixture. Filter into 2 Coplin jars. For the tartarate resistance, add 75 mg of tartaric acid in the 10 ml of filtrate. Incubate at 37 degrees for 1 hour in the water bath. Wash and counter stain with methyl green for 10 minutes. Wash, dry, examine under the microscope. The reaction products is a red with a mixture of granular positivity. In T cell, acid phosphatase is usually positive, showing localized activity. Result: find out the number of the cells showing positivity in acid phosphatase slide. Find the number of cells showing positivity in the tartarate resistance slide. If the positivity is seen in the both slides, then the test is positive for hairy cell leukemia because cells are resistant to tartaric acid. And if the tartarate slide is negative, then the test is negative. The next stain is non-specific esterase and SE. It is used as one of the diagnostic criteria for acute monocytic leukemia. We look for the presence of non-specific esterase activity and inhibition by sodium fluoride. Leukocyte esterases are the group of enzymes that hydrolyze the acyl and chloroacyl esters of alpha-naphthol and naphtholase. The non-specific esterases are inhibited by the sodium fluoride. Material required for the NSE is fixative 40% formaldehyde, phosphate buffer pH 6.3, alpha-naphthyl acetate, acetone, fast garnet JBC salt, sodium fluoride, and aqueous hematoxylin. Procedure for the stain. Take two slides of the same patient. Mark one slide as NSE and other as a fluoride. Fix in the formalin vapor in the petri dish and keep at 4 degrees centigrade for 20 minutes. Wash the slide in running tap water for 30 seconds. Prepare the incubation mixtures by dissolving alpha naphthyl acetate and garnet GBC in 10 ml of phosphate buffer. Mix both the mixture A and B and filter. Divide the filtrate in two parts. One part is used for NSE and other part is used for the sodium fluoride. Pour the filtrate on the NSE slide. For the fluoride, dissolve 1.5 mg per ml sodium fluoride powder in the filtrate and pour on the smear of the fluoride slide. Incubate both for the 20 minutes at the room temperature. Cover the slide rack with a wooden lid. Wash both the slides in running tap water. Counter stain with hematoxylin for 10 minutes. Keep in the running water for bluing. Megakaryocytes and the platelet series shows strong positivity and are taken as internal positive control. The reaction product is diffuse red or brown in color. The normal and leukemic monocyte stain strongly positive. Normal granulocytes are negative, but in myelodysplasia or AML may give positive reaction in varying intensity. The last stain is leukocyte alkaline phosphatase score. The purpose is lab score is often used in the patient with an elevated WBC to differentiate the reactive process from the chronic myelogenous leukemia. Lab stain is based on diazotization and coupling principle. At pH 9.2 to 9.8, the alkaline phosphatase hydrolyzes the naphthol ASB1 phosphoric acid into the alpha-naphthol. The stable diazonium salt and naphthol shall form the insoluble colored precipitate in the cytoplasm, which in turn give the bluish color to granules in the cytoplasm. Materials required are fixative 4% formalin methanol substrate, naphthol AS phosphate, store in the freezer, buffer 0.2 mole per liter trace buffer pH 9.1. Stock substrate solution, dissolve 30 mg of naphthol AS phosphate in 0.5 ml of N,N-dimethyl formaldehyde and add a trace buffer and store in the refrigerator at 2 to 4 degrees centigrade. The solution is stable for several months. Coupling azodie, fast blue BB salt, store in the freezer. Counter stain, neutral red, 0.2% aqueous solution. Method: fix freshly made air-dried blood smear either by finger prick or from the heparin blood sample for 30 seconds in the cold 4% formalin methanol. Do not use the EDTA sample. Rinse with the tap water and air dry. Prepare working substrate solution by allowing 40 ml of stock substrate solution to warm to room temperature. Add 24 mg of fast blue BB salt and mix thoroughly until dissolved. Incubate the slide for 15 minutes. Wash in tap water and air dry. Counter stain for 3 minutes in 0.02% aqueous neutral red. Rinse briefly and air dry. Reaction product is blue and granular. Overall score is obtained by assessing the stain intensity in 100 consecutive neutrophils, with each neutrophil scored on a scale of 0 to 4 as follows. 0 score is given as negative with no granules. 1. Occasional granules scattered in the cytoplasm. 2. Moderate number of granules. 3. Numerous granules. And 4. Heavy positivity with numerous coarse granules crowding the cytoplasm, frequently overlying the nucleus. The low score found in CML, PNH, and hereditary hypophosphatasia. High scores are seen in neutrophilia of infection, leukocyte reaction, polycythemia vera. These are the references for this special strain. Thank you.